Well, good afternoon, or should I say good evening, everybody. It's CNY Fertility Colorado. I'm Dr. Randy Fink, and welcome to Fertility with Fink and Friends. I'm so happy to have everybody joining me here, top of the hour. It's 4 o'clock p.m. Mountain Time. Oh, it's about 40 degrees outside in Colorado Springs, but another beautiful day. And hi to everybody who's joining. We've got Facebook here in the middle. We've got a couple of Instagram feeds here, and we're also on LinkedIn at this time. So very glad that you're all with me here, and I hope that you'll have your friends join as well. We're going to talk about everything from fertility to women's health to all those things that are on your mind. Today, we'll just really ask for your questions and want to know what you're thinking about and kind of what's going on. You know, we've been paying a lot of attention to egg banking recently. And if you follow my feed at Randy Fink MD on Instagram, then you'll see I just did a video, which I thought was kind of funny, that looked at, I looked at a dozen eggs that we, kind of put in the freezer with the ice and the frozen meat. And I said, no, is that egg freezing? No, that's not egg freezing. Egg freezing, of course, is the process where a woman can store her eggs in advance of needing them. And so this really turns out to be it's an insurance policy. And people ask me, well, how many eggs do I need? How many do I need if I'm going to save my eggs? And saving eggs is probably one of the smartest things I think you can do, because in our world, so many of the people that we're taking care of who are trying to get pregnant are dealing with an issue of decreased ovarian reserve. So, of course, the number of eggs we have diminishes over time, as does the stability of the DNA, the genetic material in those eggs, so that when it comes time to use them, it may be more difficult to produce eggs. It may be more difficult to produce an embryo that's chromosomally normal. It may be more difficult, certainly even in nature, just to have a baby. And that's really the reason why. So when we freeze our eggs, it gives us the opportunity to be able to use eggs later on that were retrieved at a younger age, at which point they likely have more DNA stability and may be more useful later on. How many eggs do I need? Well, if you've ever had to buy insurance, let's say life insurance or disability insurance is probably a good one. However much insurance you buy, if you have to use it, is never enough. But if you don't use that insurance for anything, then whatever you have was too much. So I don't think there's really a right answer as to how many eggs you really need in order to feel comfortable. It's a very individualized thing, and it's something that, of course, we'd be very happy to talk with you about. So if egg freezing and fertility preservation is something that might be on your mind, pick up the phone and give us a call. Because paying attention to that egg freezing is something that I really wish, as a general gynecologist, I had said to people long, long ago. Now it's a very easy thing to do at CNY. It's a very inexpensive thing to do relative to some other places. I've seen places where egg freezing might be $17,000 to $20,000. Currently, it's $29.95 at CNY Fertility. So again, if the time is right, pick up the phone and give us a call. We are, hi Amber. We are getting a lot of questions here on the Instagram side. So let's see if we can't go there. By the way, if you see that my eyes are darting about, it's because I got a bunch of different cameras here. And that's really the reason why. It's so nice to see all these familiar names and great pictures, great faces joining us here. So really appreciate having you. So here's a question. I'm 37. And I got my tubes tied 4 years ago and was told that I cannot get them untied and I would really love to have a baby. That's a common reason that we will have a consultation here at CNY Fertility for people who have had a tubal ligation. So when we do a tubal ligation, the first thing that I would always do as a general gynecologist would say, I just want to be 100% sure that you never want to have another baby. And the answer is, of course, well, yes, I'm sure of that. But of course, things change, the world changes, and maybe it comes to a point where you do want to have another baby. When there can be several different ways that we perform tubal sterilization. So the current recommendation is that we actually remove the fallopian tubes. That we remove the fallopian tubes because early ovarian cancer is thought to originate in the fallopian tubes. So if we actually remove the tubes, then not only are we providing the sterilization that you seek, but potentially also decreasing a risk factor for ovarian cancer later on in life. Another method is to put a clamp on the tube. Another method is to lift the tube like so and to put a ring on the tube so that it's blocked. The whole point is to block the highway so that sperm can't meet egg. So how can you undo that? Well, in theory, if you've got a blocked portion of tube, by the way, one other way that I see people do, I notice it seems to be more common here out west, is that they will use cautery and just burn different segments of the tube in order to damage it. Which functionally serves the same purpose. But if you've got a knot in the tube or a knuckle in the tube or some individual blockage, you can theoretically remove that blockage and then sew the two segments of tube back together. And that's called a tubal reanastomosis or a tubal reversal. If the tube was sterilized by burning it all the way down, that's something that's a lot harder to reverse. The problem is that when you put tubes back together, that process doesn't always work. It can leave behind scar tissue that can still occlude the fallopian tube and prevent sperm from being able to reach egg. So untying the tubes or reattaching the tubes may not be successful. And once there's an injury inside that tube, it increases the probability of having an ectopic pregnancy or a tubal pregnancy. And it increases that fairly substantially. And a tubal pregnancy is something that's potentially life-threatening. So it's something that we don't want to miss. So what can we do instead? We can do IVF. So IVF is the process where, of course, we are giving you medications to rev up the ovaries in order to get you to produce as many eggs as we can get, which we retrieve from the ovaries under some anesthesia. We bring those eggs to the lab. We have partner sperm. One sperm goes in each egg, and that creates your embryos. Now, to do a tubal reanastomosis carries anywhere from a 20 to an 80% chance that it will be successful. Whereas when we do IVF, we can give you up to a 60% chance of success per embryo, depending, of course, on what we do and who you are and what you bring to the table. So many people will opt for the more certain treatment of IVF as opposed to another surgery where you try to put the tubes back together. The other problem is that putting the tubes back together is not something that's generally covered by insurance. CNY does offer this service out of New York. Dr. Kiltz is an expert when it comes to putting tubes back together. So that's also something that we can help you with by giving us a call. Can we talk about medicated versus modified natural transfers for a frozen embryo? And I think that's a brilliant question. So thank you, Haley's mama, for bringing that up. The medicated embryo transfer has been around since IVF was invented. That's what we've been doing since we started with IVF. And in the medicated cycle, well, here's what the thinking was. Well, there's really nothing natural about doing IVF. So why do we need to do anything natural, right? We're going to control every single variable and thus we may be able to get you pregnant. That's how the whole thing works. With a medicated cycle, you get 6 to 8 days of estrogen, which thickens up your lining, followed by an ultrasound that shows that the lining is thick enough, and then 6.5 days of progesterone, and then you end up with your transfer. Well, that's a medicated cycle. In the modified natural cycle, think about this. If you weren't going through a treatment with a frozen embryo, what would your body be doing? You make an egg every month if you ovulate and if you have a monthly period. So that follicle in the ovary, that's a little egg that's surrounded by some cells. And those cells are called granulosa cells. And the granulosa cells are a little estrogen making factory. So you're going to develop your egg, which is going to grow and grow and grow until it reaches the point where it wants to ovulate or get released. And of course, in nature, it's getting released so that sperm can come along and fertilize it, right? But as the egg is growing, you're making more estrogen, which is thickening up the lining of the uterus. Then what we can do is say, well, your egg is mature, so we can go ahead and trigger your ovulation so that we have some control over when you're going to do your transfer. We give you a little trigger shot, which starts the timer on when you're going to get your transfer. Your ovary releases the egg, and when that happens, that little estrogen making factory becomes a progesterone making factory. So instead of giving you 6.5 days of a progesterone shot in your butt, your body is making its own progesterone. Now, we give you extra progesterone because you really do need a bit more progesterone, but it does save your butt from a few extra shots, and that's important. The other important thing is that that progesterone that your body is making may just be the magic sauce, because the data shows us that with that modified natural program for an embryo transfer, there's a little higher pregnancy rate, there's a little lower miscarriage rate, and more importantly, there's a significantly decreased incidence of blood pressure complications later on in pregnancy. And it all goes back to you making your own progesterone. Again, we give you more progesterone. Ultimately, you get your embryo transfer, and we still give you the progesterone oil and oil shots. So your butt has to see the needle anyway. Some people don't like to do that progesterone shot. They say, well, can I do this without the shot? You can. You can use vaginal estrogen, but the outcomes aren't as good. We prefer you to be able to use the progesterone and oil shot, because when you use vaginal progesterone only, the pregnancy rate is significantly lower. So we want you to be pregnant, but I am a big fan of the modified natural cycle. Now, what's the downside of that? Why wouldn't we do that in everybody? And the answer is we do need control over many aspects of the cycle. So some people don't ovulate on their own. They won't release their own egg. And we have some solutions for that. But the other issue may be that if it turns out that your transfer is going to take place on a Sunday, well, guess what? We're not open on Sundays. None of our locations are open on Sundays. And so it may turn out that your cycle gets canceled and you have to do it the next month. So that's why we do that modified natural. Instead of letting you release the egg on your own, we wait until the egg is mature, and then we trigger it so that we do have some control over when you're going to have your transfer. And that's important because so many of our folks are traveling to come see us here. By the way, if you haven't been to Colorado, I'm just saying, Colorado Springs, CNY Fertility, not a bad place. Boy, we have some great people working here. And I can't tell you what a pleasure it is to come to work here every day and to meet such nice patients and to work with such great people. So Haley's mama, hopefully I answered that question. Hey, baby gap 3, is it okay to start IVF stim with a cold? Yes, it's okay. I wish that maybe I'm a conspiracy theorist, but it's hard to believe that they can't come up with a cure for the common cold. The cold industry makes billions of dollars a year with the over the counter medications. And so I don't know. We're going to dispense with conspiracy theories on fertility with Fink and Friends. But yes, you can start. IVF stim with a cold. Hey, going up to the Facebook side. Hi, everybody. So Asim wants to know what comes after the IVF transfer. Well, that is a very good question, because once we do the transfer, we like you to take it easy for the next 2 days. So what I tell people is that I don't want you doing, and maybe I've told you this before, so if I've done your transfer, you've probably heard my jokes, but so forgive me for being repetitive, but no skydiving, no BMX, motocross racing, no extreme snowboarding, no lumberjacking. Alligator wrestling is definitely off limits for 2 days, and then you can resume alligator wrestling. So what comes after? You take it easy for 2 days. You can live a pretty normal life, because we're a pretty resilient species. There's not a lot of things that you can do that will necessarily harm you. And if bouncing around in a car was something that was going to prevent our species from being able to perpetuate, I don't think we would have made it really this far. So generally speaking, take it easy for 2 days. It's pretty safe. We do some midway labs, and the midway labs are designed to show us really your progesterone level. And depending on what type of embryo went back in you, typically anywhere from 10 to 14 days, we do your pregnancy test, and that's when we get the good news. So let us hope that's what comes for you after your IVF transfer. Is letrozole required for a modified natural transfer if you have no ovulation issues? The answer there is no. So in my consultations, when I talk to patients about modified natural, I will usually put in the orders no letrozole. Letrozole is a medication that we take orally that stimulates your production of the FSH hormone, follicle stimulating hormone, and that's what causes you to recruit an egg. So if you don't ovulate, we can give you letrozole, and that's going to make you form an egg in your ovary that will eventually get released. There are some in our company who like to use letrozole with a modified natural because they want to make sure that you are going to ovulate in a predictable fashion. My feeling is I don't think it's necessary. And in fact, we're putting chemicals and manipulating hormones where they may not need to be manipulated. And what kind of effect does that have downstream? Who can say? So it's really a preference thing. And in my mind, I say no, you do not have to have letrozole if you ovulate normally and you're doing a modified natural transfer. Well, let's see. Lacey's going to be in Colorado in March for IVF. March is a good time to be here. And and Casey's going to be here on Monday for a transfer. We're happy to have you. We're going to have balloons and cake and that sort of thing. I think it's just appropriate. That's just my 2 cents worth. All right, what else we have going on here from the Instagram side? Here's a question. How many eggs do you have to take out? Well, I presume you're talking about being able to, in an egg retrieval, how many eggs do we take out? When I do a retrieval, I'm fond of saying no egg left behind. No egg left behind. If I can see a follicle, I am going to put a needle in it and try to extract that egg. Now, we want most of your eggs, when we retrieve them, to be mature. But sometimes an egg comes out that is not yet mature. And so we hold those eggs in the lab to see if they will mature overnight, and some of them do. So that's why any egg that seems to be there in a follicle that we can see will result in that egg being retrieved when I'm doing it. Now, I've seen some other folks who will say, well, if there are if the eggs are small and may not be mature, then there's no sense in taking them out. But my feeling is I don't want to leave them there. They continue, they may just provide you a baby, and they also continue to make estrogen, which can make you feel not so good after your egg retrieval. So good question there. Hey, are we seeing good success with fish oil intralipids? Have you guys done intralipid? You know what intralipid is? So at CNY, we do an immune protocol for just about every patient who is undergoing fertility treatment, because we know that inflammation in the immune system is something that can be a cause of infertility and cause you trouble in being able to get pregnant. One of the things that goes along with our immune protocol, starting at the immune protocol level 2, is called intralipid. And it's a little IV bag. It looks like a milkshake. So I'm always joking about that. Oh, you're getting your milkshake there, are you? It's vanilla. The intralipid is commonly made out of soy. Lipid is a fat. And so kind of what it is it's an IV infusion of the keto diet. So it's very anti-inflammatory and seems to be a good thing for us. But there has been a shift away from the soy-based intralipid to now fish oil. Have we seen good results with it? People seem to like it. People don't seem to mind having the infusion. So I would say the answer to that is yes. And if you're thinking about adding intralipid to your protocol, or if it's part of your protocol and you're trying to decide whether you want to do it, it's a pretty benign, it's a pretty innocuous process. So I would encourage you to look at that. So modified FET, can you still use a trigger shot if you have no fallopian tubes? And the answer is absolutely, because those things are working in a different place entirely. So the trigger shot is telling the ovary to release the egg. The fallopian tubes don't have too much to do with that, because what we're going to be doing then is we're going to be placing an embryo that we've already made right back inside the uterus. So the presence or absence of the fallopian tubes doesn't really have too much to do with the IVF process or the embryo transfer process. Good question there. Oh, let's see. What do we have here again on the Instagram side? Do you recommend fresh versus frozen for a patient with PCOS? So I am going to go on the assumption that pretty much everybody here who's involved with us knows what polycystic ovarian syndrome is. It's a metabolic syndrome that can involve a very wide variety of different presentations. Some people are thin, some people are heavy, some people have a lot of extra hair growth and high testosterone levels. Some people have acne, some people have a thickening of the skin on their neck, which has a name that's called acanthosis nigricans. Big word, right? Well, just to prove to you that I remember something from medical school. I have to be honest. PCOS is really something where it tells me, when I find out that you have PCOS, it tells me how your ovaries are likely to respond to the medication that we're giving you to stimulate them. And that means they typically pay really close attention. They pay really close attention. So a little medication goes a long way with PCOS. And what can result in that is a bit of hyperstimulation. Hyperstimulation can become a syndrome where you end up retaining water and you end up actually can become pretty sick from that. Because remember, we talked about those granulosa cells. The granulosa cells are the little cells that ring the follicle that contains the egg. And those granulosa cells make estrogen. So the more eggs you have, the more granulosa cells you have, and the more granulosa cells you have, the more estrogen you're going to have. And the higher your estrogen, the greater the risk you are for developing the ovarian hyperstimulation syndrome. Now, so women with PCOS have a tendency towards responding really well, making a lot of follicles and having a high estrogen level. And if that's the case, then a frozen transfer is probably the better bet. Because think about it this way. This is the reason that frozen embryo transfers, and certainly in particular populations, may have a little higher success rate than a fresh transfer. And that's because your ovaries, your body is 100% in egg making mode when you're doing that IVF stimulation and retrieval. Much more so egg making mode probably than you are being in pregnancy mode. So if you have PCOS, there's a good probability that we're going to end up telling you that a frozen transfer might be a better bet than a fresh transfer. So hopefully that answers your question. Here's a question. Can I donate my eggs? Oh, you know what? We haven't talked about egg donors here on Fertility with Fink and Friends, I think, since we've started doing this. CNY Fertility does have an egg donor program. So for folks who need to use donor egg, you can get those right in-house from our donor team. We can connect you with the donor team, or you can email through the portal to the donor team to ask about that. But where do the eggs come from? They typically come from younger reproductive age women. There are certain criteria that are involved with becoming an egg donor, and egg donors are compensated. They are paid in addition to having the medication and all the care provided. So if you're interested in becoming an egg donor, please do reach out to us at CNY. We would love to talk to you. I think that's probably one of the greatest gifts that you can give to another person, is to help them to have their baby. I've got a question from one of the Instagram feeds. I had a hydrosalpinx. Hydrosalpinx is a fluid-filled fallopian tube. A fluid-filled fallopian tube. The fluid that's in those tubes can drain back into the uterus and can become toxic to an embryo. So when we see someone who has that inflammatory fluid in their fallopian tubes, we typically recommend that those tubes be removed. And that's exactly what happened here with, I don't want to mispronounce it, Iandre, 28. Thanks for being here with us. So you had your tubes removed. What are the chances for success with an FET? 36 years young. And it's a good question. The answer is your odds of success with an FET are just the same as they would be for someone who had normal fallopian tubes. Now, again, having the hydrosalpinx means that that fluid can be toxic to an embryo, and so the success rate of an embryo transfer goes drastically down when that hydrosalpinx is present. So removing the tubes is the treatment, and that puts you on even footing as anyone else who has normal fallopian tubes. So hopefully that answers your question there. All right, what else do we have? Is AMH being low for my age a concern? Well, that comes from Rebecca McNally. Hi, Rebecca. Glad to have you with us today. By the way, if you're just joining, it's 28 minutes after the hour. 28 minutes. We'll probably keep going for another 20 or 30 minutes here. CNY Fertility Colorado. I'm Randy Fink, and this is Fertility with Fink and Friends. You are my friends, so thank you for being with me today. Low for the age. The AMH is a hormone level called the anti-Mullerian hormone that tells us about your ovarian reserve. It's what we call the ovarian reserve hormone. And when that number gets less than a 1, we start thinking about that as what we call diminished ovarian reserve. And with diminished ovarian reserve, there are certain protocols that we use to try to maximize the ovary's performance, right? And so it just changes the way we think about how the ovary is going to respond. And so it changes the way we medicate the ovary. So low for age only means that, well, if we look at a nomogram, considering age with values of what that AMH is, you may be ahead of the curve or you may be a little behind the curve. But the AMH is not a measure of whether you are going to be able to get pregnant or not. And that's a very important thing to know, Rebecca, that AMH is not a measure of whether you will be able to get pregnant. It merely tells us how your ovary might respond to our medications. So, is it a concern? Well, it means that, okay, the clock's ticking. If we're going to do something to get you pregnant, we'd like to do it sooner rather than later. That's really what it tells me. Bradley says, I wish my OB had told me to freeze my eggs. And again, I say the same thing. If the technology really wasn't so much there 10 years ago, we didn't know a lot about freezing eggs and about thawing eggs. And frankly, we didn't know as much about, freezing embryos as well either. Now that process is so very effective. It's so successful that I believe every woman, especially those under the age of, let's say, under 35, should be able to have that conversation with their doctor about saving eggs. Our wonderful nurse practitioner here, Brandis. Hi, Brandis, if you're on. Brandis says that there have been situations where patients have told her that they talked about it with their doctor, and their doctor said, nah, don't worry about that yet. You're only 35, so you don't have to, that doesn't concern you yet. And the answer to that is maybe it's time to get a different opinion, because the younger we are when we retrieve those eggs, the better off those eggs are going to do for us. So on to the Facebook side. Hello, everybody. And Asim Khan's doing a fresh transfer. Okay. Your wife had one egg retrieved. If it isn't mature, what happens next? So if an egg isn't mature, we try to mature it in the lab so that we can fertilize that egg with sperm. Here's Amanda. Hi, Amanda. Glad you're here too. I did an ovarian PRP. And happy with the results on number 7, number 8 egg retrievals. Ouch, that's great. I'm so happy to hear that. So ovarian PRP is probably something that's good to mention. Amanda, thank you so much for bringing that up. What is PRP? PRP is platelet-rich plasma. And what we do with PRP, if you've heard of it before, they use PRP in aesthetic medicine. You can inject it into the face and it helps with wrinkles. You can inject it into the scalp. It helps to regrow hair. You can inject it into an injured joint and it helps it to heal. Someone figured out the way to be able to take a tube of your blood and to separate out your body's healing components, the tissue factors, as we call them. So your growth factors, your healing factors, and that's what's called platelet-rich plasma. PRP can make us younger. So for folks with diminished ovarian reserve, one of the things that we can do is to place your own healing factors to separate them out in your blood, and with a little needle, like we were doing an egg retrieval, simply inject that PRP right into the ovaries. And that may cause the ovaries to respond in a favorable way. And as we see from Amanda, seem to make a difference on her next egg retrievals. We can do that at the time of a retrieval if you're planning to do another retrieval. And it sounds like that's what Amanda did. So she's prepping for a transfer. At what point would we recommend uterine PRP? Well, that's another type of PRP that we can use. We take that same platelet-rich plasma, and instead of injecting it into the ovaries, we place it through a little transfer catheter to bathe the lining of the uterus. And when we do that, think of it as the most soothing salve your uterus could imagine. Two common things we do: an HCG wash and a PRP wash. They can be done together. We mix them together and can go in all at once. HCG is, of course, the pregnancy hormone. So when we put that pregnancy hormone inside the lining of the uterus, that causes the cells inside to upregulate some of the proteins that are associated with embryos sticking. So that's what the HCG wash is for. And the PRP is going to soothe that lining, add growth factors to it. It is particularly good for those who have had a transfer before and were unsuccessful with it, or in those who've had recurrent miscarriages. So that's usually done in the day to 2 days before the transfer. And it's done in our office. So thanks, Amanda, for that great question. Oh, my friend Amber wants to know is if someone's wanting to do ovarian PRP, how many rounds before doing another retrieval? And that's a good question too. So the problem is that PRP in the ovaries, and in fact, even PRP in the uterus, is considered experimental. So there's not a lot of great data that tells us this absolutely works. Nor is there data that tells us this is the precise protocol that we need to use in order to get that there. So we're kind of doing what we think is the right thing. And I can tell you that empirically, it seems to make a difference. So how many rounds? I usually tell folks if you can do 3 rounds of PRP, I think you're making a sound decision. If you can only do 1 round of PRP, I think you're doing something that's better than nothing. So is more than 3 rounds of PRP useful? Personally speaking, based on what I've read, I would find it hard to tell you that doing more than 3 rounds of PRP into the ovaries is useful. Is it useful in going into the uterus before a transfer? And I think it's useful going into the uterus before a transfer, literally before every transfer. So thanks, Amber. Appreciate that question here. There's a question from Sally. What are the prices for PRP? And I'm afraid that one I have to defer to the website. I believe that information is on the website. People ask me about pricing all the time. I do the medical part. I don't know so much about the prices, but that information should not be difficult to come by. I will tell you that one of the nice things about CNY fertility is that sorry, my train of thought got derailed because I saw a comment from a friend there. One of the nice things about CMY is all the pricing is up front. There's none of these, we don't see hidden costs creeping up. And it's what I call, that financial extraction technology is not something that we specialize in. I'm very proud that we can offer the pricing that we do because everyone has the right to have a baby. CNY finances people. CNY really offers the lowest cost IVF in the country, and I'm so proud to be a part of that. So pricing should be available to you. Is Avidrel the same as a Lupron trigger, or is it equivalent to HCG? Well, so Avidrel is basically what we call a recombinant or a manufactured form of HCG. So it's not the same as Lupron. It's the same thing as an HCG trigger. The HCG triggers that we use in IVF and infertility are typically high dose medications, while the Avidrel, so Avidrel would be a high dose HCG, while the HCG LH that we use during the stimulation portion of IVF is typically low dose. So hopefully that creates a little distinction. Which wash is best for a patient with diminished ovarian reserve or someone with a low AMH? Well, the low AMH and the ovarian reserve part really has to do with producing the eggs in order to make the embryos in order to be able to do a transfer. The wash part has to do with the transfer. So, I would think at minimum, an HCG wash is very useful for transfer, but I don't think a question of ovarian reserve or your AMH should weigh into that equation. That has more to do with how we're retrieving the eggs. Oh, let's see what else we got here. What can you use? Oh, this comes also here from Sally. What can we use to improve our egg quality? That we look at something called priming. And we've talked about priming before, so I'll review it just briefly here. To prime you is to give you medications before you do your IVF stimulation. And those medications, typically estrogen and progesterone, those are the languages that the ovaries speak. So it increases blood flow to the ovaries. It causes you to create new blood vessels. It helps the eggs to grow. It helps the ovary to be healthy. We typically use low-dose naltrexone, which stimulates your in the brain your endorphin, and endorphins have a direct effect on fertility. We use Omnitrope. Omnitrope is human growth hormone. Omnitrope is a common brand of human growth hormone, and that's usually what we use. By the way, I just want to throw out there for anybody who has to use or is using HGH, that's human growth hormone, or Omnitrope, particularly Omnitrope in their cycle, if you don't have the coupon for Omnitrope, it is available online. That coupon, so if you just look up Omnitrope coupon, OMNITROPE, Omnitrope coupon, that will take you to the link where you fill out a little survey. It will give you a coupon that will get you the Omnitrope for free. And I have to say, free is pretty good. Free is good when you can get it, especially in this process where things cost money. It's nice to have something for free. So Omnitrope can come free with the coupon. What growth hormone does is in the anti-aging community, it's what keeps us young. We give people growth hormone because it helps with fat loss and muscle gain and all other things, many other things that are good and associated with anti-aging. We don't use it in folks who have had a history of cancers because that's a contraindication to its use. But imagine if you use growth hormone and it's going to make your skin shine and make you feel, youthful and vibrant. What's it going to do to your ovaries? Well, how's it doing that to your skin? It may have the ability to be able to repair some of the age-damaged DNA that's in the ovaries. So that's why we use it, and that's a good way to improve egg quality by the use of priming. All right. Well, let's see here. Oh gosh, this comes from Luli313. Luli had an ectopic pregnancy and had to get, looks like, both tubes removed. And so that means that IVF is really the only choice for being able to get pregnant, because the tubes are the place where the sperm travel to meet the egg. Fertilization in nature takes place in the fallopian tubes. So if the tubes are gone, then IVF is really our only option. Fortunately, IVF has come so far by now that it's really down to a science. We have it, we can predict very easily how people are going to respond. And I think probably, in my experience, and again, I have gone through more cycles of IVF than anybody else, although I've never had my eggs retrieved. So I bet you could tell us what's the worst part about IVF. I think the answer would be one of a couple of different things. One, the shots are probably no fun. Shots are definitely no fun. Secondly, I think it's the wondering and the waiting. It's the anxiety over waiting for the pregnancy test or what the outcome is going to be. I think that's probably the scariest part about IVF. But I have to tell you, Luli, that there are so many wonderful people out there on the CNY support pages who can help you through every step of the way. I have been so impressed with how willing our patients nationwide are to lend a hand to other people who are going through or who may be starting the process that they've already been through. So reach out and ask these folks for help, because I promise you that help is there. Oh gosh, so many nice people to be here with me now. Almost a quarter till the hour. We'll keep going for a few more minutes as long as you have some questions here. Let's see. How do we make our own progesterone? Asks looks like Felicia. How do we make our own progesterone? Progesterone predominantly comes from the portion of your ovary that's called a corpus luteum. The corpus luteum. So when your ovary releases its egg, it's like a car leaving a garage. It leaves behind an empty space, and that space then fills up with fluid. By the way, sometimes that fluid is blood, and that can be what's called a hemorrhagic cyst. And those things can hurt. So I'm sure many of you have probably had to go to the emergency room for some kind of pain and were told that you had an ovarian cyst. A lot of times those cysts are really just the follicle, just the egg that's growing in the ovary. Or it may be that the ovary has released its egg, you've ovulated, and you filled that space with blood. And sometimes that can even rupture and cause you even more discomfort. But the cells that are inside that follicle after the egg is released is called the corpus luteum. And the corpus luteum makes progesterone. That's where your progesterone comes from. And it typically makes that through about 9 weeks, at which point then your placenta takes over and it starts making your progesterone. Now, if you don't get pregnant, what happens? That progesterone realizes, oh, wait a minute, we got nothing to do here. And so the faucet turns off, the progesterone level drops, and that's the signal for you to have a period. So that's kind of the way that thing works. How soon after endometriosis surgery can you start IVF? Hey, Clark, that's a good question too. Endometriosis is such a frustrating problem. It can show up in people who we don't know it's there. It can stand in the way of successful transfers. It can stand in the way of natural fertility. So there's a couple of different ways that we can diagnose endometriosis. The classic way is through surgery, and that surgery is a laparoscopic surgery. So a little camera goes in through your belly button under general anesthesia, and we can look around, see what's there. If there's endometriosis, which is where that lining of the uterus that normally sloughs off during your period, instead implants in sites around your abdomen. So we can treat that surgically. We can also diagnose endometriosis non-invasively. And if you're not familiar, that's a test that's called receptiva. Receptiva is an endometrial biopsy. It's a little straw that goes into the uterine cavity and sucks out a little piece of tissue at just the right time during the cycle. It is cycle dependent, so you have to do it at a particular time during your menstrual cycle. And it looks for the presence of a protein that's called BCL6. BCL6 is an inflammatory protein that is associated with endometriosis. It has about a 90% sensitivity and specificity, meaning say it's a pretty good test that if your BCL6 marker is positive, then you have endometriosis. So we can also diagnose that way. If that's the case, then typically we treat you with medication for about 60 days before doing an embryo transfer. We want to suppress the endometriosis because of the way it interferes with the hormones talking to each other. If you've had surgery for the endometriosis, typically a month in the next cycle, you can really start the IVF process. Sort of depends on how how bad the endometriosis was as to when we might think about doing an embryo transfer. But as far as retrieving eggs, pretty quickly after endometriosis surgery. Here's from my friend Taryn. Hey, Taryn, it's nice to hear from you. Nice to see you there. What do we recommend for a recurrent implantation failure? You've done many of those things there. Laparoscopy, hysteroscopy. So the first thing I want to know is what's going on. So she's talking about when you keep doing transfers, but they're not working. What's our evaluation? Why did our transfer keep failing? Hysteroscopy, I think, is probably one of the more important features because we want to know that mechanically what's going on inside the uterus is normal, that you don't have scar tissue, that you don't have polyps, that you don't have a band of muscle, or something that mechanically might be standing in the way of an embryo trying to implant. The laparoscopy is designed to look for endometriosis, which again, we can also diagnose non-invasively because endometriosis messes up the way the brain talks to the organs via the hormones. We want to look at the lining of the uterus. We want to know, is there an inflammatory process? And that's called chronic endometritis. And that can be diagnosed by a little endometrial biopsy. It's a little straw that goes in, sucks a little piece of tissue out. The washes and ultimately the immune protocol. So when all else fails, when we can't figure out what else is going on, the diagnosis of exclusion is, we have good embryos, we have a uterus that by all accounts should be normal. The presumption is that this is an immune system problem. So that's generally when we pull out the big guns. The big guns is our immune protocol level 4, which can involve a medication called Humira. It can involve something that's called IVIG or intravenous immunoglobulin. That's probably the biggest gun anti-inflammatory that we have. The problem with IVIG is that it's expensive. And so why wouldn't we offer it to everybody every single time you're going to do a transfer? Because it's very costly. Now, there are ways that we can get it less expensively, and we can help you with that. But IVIG is often what we turn to when we don't know why else the transfers are failing. So, Taryn, my fingers are crossed for you, my friend, for sure. Well, we got just a few more minutes here. Here's a good question. It asks about prolactin. Can I have IVF with high prolactin? The prolactin hormone is the one that comes from the pituitary gland that causes lactation in the breasts. Some people have a growth in the pituitary gland in the brain, which we call an adenoma, that makes too much prolactin. So usually what happens when someone has an elevated prolactin level, which is one of the things that we will test as part of our preconception testing, we want to know why. Because if they have an adenoma, it means it's something that we want to be able to treat. And there's a simple medication that will make that little growth shrink down. So people having to have surgery for that type of growth in the pituitary gland is fortunately really quite rare. The medicine is Dostanex or cabergoline is what it's called. Typically, it's taken twice a week. And we want that prolactin to be normal because when it's not normal, it interferes with the way the ovaries produce their eggs. And so we typically do treat that. Now, some people will have an elevated prolactin, and it's just because of some extra tissue in the pituitary gland and not actually a growth. Some people on the preconception labs will have an elevated prolactin, and it's because of breast stimulation. So we can stimulate our own nipples to the point where the prolactin level goes up. So when a patient has a mildly elevated prolactin, one of the things we typically do is to repeat the test, but without nipple stimulation in the preceding, let's say, 24 hours. It also can have some variation in the time of day. So we usually ask you to repeat that fasting. Well, I think we'll have time. Here comes from one of my dear friends in Miami. I was so scared of those butt shots, but they aren't so bad. So don't be scared. Thank you for that. That was he, and that's just the kind of information that you get from people who've been through this process. People who are always willing to help. Oh, Babyface says, I love the Colorado location. Everyone was so friendly. Okay, you can keep telling me things like that. I don't mind hearing it. Hey, folks, looks like we're going to end up wrapping up for today. I want to say thank you so much to everybody who joined me here, Fertility with Fink and Friends. My name is Randy Fink, and I am the Clinical Director of IVF Services here at CNY Fertility Colorado, where what we want more than anything is for you to be knowledgeable and for you to have that baby. Fill that void. Let us help you. God bless you all. Thank you so much for being with me today. Join me next week, won't you? Same time, 4 p.m. Mountain Time for Fertility with Fink and Friends. And until then, call us if we can help. Be well.